Hello and welcome to the American Academy of Pediatrics. My name is Shreen Khan and I'll be your moderator. Today is the second in a four-part series that we're doing on iKMC, focusing on readiness and implementation. Now, if you missed the first of our series, do check it out. We'll put the link in the chat. It's a great conversation that you don't want to miss. Today, our program is being translated live in 3 different languages: Spanish, French, and Portuguese. So if you'd like to listen in another language, click on the globe in the bottom of the Zoom window and select the language of your choice. Now, to our audience joining all around the world, welcome. Please put your questions and comments in the chat box, and we'll get to them in the second half of our program. I'd like to introduce you to our panelists that are going to be joining us from all around the world. Starting in Stockholm, Sweden, we have Dr. Nils Bergman. Nils, how are you doing today?
Fine, thank you very much.
Excellent. So Nils is one of the foremost experts on iKMC. He's a neonatologist and consulting physician conducting research at the Karolinska Institute in Sweden. He also has extensive expertise in South Africa, Zimbabwe, and Sweden. Next to Nigeria, we have Professor Chinyere Ezeaka. Hi, Chinyere. Chinyere is a professor of pediatrics at the University of Lagos. She heads the neonatology and perinatology unit at the Lagos University Teaching Hospital, and she also leads at Nest 360, a global health alliance working in sub-Saharan Africa. Next, we'll go to Munich, Germany. Thank you, Chinyere. In Munich, we have Silke Mader. Hi, Silke.
Hello, good morning, good afternoon.
Good morning, good afternoon. Silke has an incredible personal story where she was a mother of preterm twins and actually lost her daughter, and that pushed her into a life of maternal health advocacy. In Germany, she's founded the European Foundation for the Care of Newborn Infants, among other organizations. Silke, thank you so much for joining us.
Thank you.
And stay tuned, we will have another guest joining us if she can zip from the maternity ward home in time. So what I want to jump into is showing you all a clip of the how. So with iKMC, especially in our first session, we got so many questions on how to actually implement the zero separation between infant and mother, especially when babies are born preterm. They're very weak and fragile. So we're going to take you into the delivery room in Norway and show you exactly how it works. So have a look at this video.
Skal de vente med å tørre klær? Ja. Det greit å ha tøy sånn? Jeg bare kjenner det litt på magen. Ja, det ligger der. Det klart. Der klarer du ikke bare her. Du så god. Ja, nei, den. Jeg der oppe kanskje. Ja, men arteri. Ja, det ligger 2.
Okay, so we can see in that clip how fragile the infant is. And I'm just going to remind Nils to unmute himself. Nils was in the room during that delivery, and Nils is going to walk us through the technologies at play. So Nils, tell us what we saw.
So firstly, this baby is 29 weeks and 1,200 grams. And as you see, the filming starts at the moment of birth. And the first technology is a piece of plastic. And the second one is a warm towel, warmed by a hot water bottle. Everything is prepared then you see CPAP, it's near puff. So within 10 to 12 seconds, this baby is getting CPAP, anticipated respiratory distress. We don't wait for it to show itself, it's preemptive. And then there is a moment of bit of busy fingers that we don't really like. And then auscultation is taking place around about before a minute, the heart rate's fine. And then an saturation monitor is installed onto the hand. Notice that it's quiet, it's peaceful, and everything is there. And it's all quietly done within a minute.
Perfect. Thank you, Nils. And in terms of implementation of iKMC, there's 4 really key elements that I want everyone to leave with today, and it's the 4 S's of implementation. So that's staff, space, stuff, and system. So we're going to run through the 4 S's and chat through each of those and how they all work together. So Nils, I want to go back to you. Give us a brief overview of the first 2 S's of staff and space with iKMC implementation.
So the first thing is, for it to be immediate, the neonatology unit, staff, doctors, nurses, need to be part of the OR, operating room, and the delivery ward. This requires significant system change very often. And with them, every piece of equipment that they're familiar with. There shouldn't be the additional stress of a transfer. Everything can be done on site. Here you see a baby that has had 2 days of corticosteroids and is doing okay just with CPAP, and it's near puff that you could do a bit of extra support if you needed to. There is a resuscitator right there, as there is always in any other unit, and intubation can be done, and then the baby is returned. So the philosophy here is that skin to skin isn't a kind of care, it's contact. Skin to skin contact is a place where the care is given as it always was. Yes, with some skill set development required to accomplish this. Further along the line, there is an obstetric care. Perhaps I'll point out also that obstetric care is influenced profoundly by this. One of the very simple things that happens is that we can avoid cutting the cord. So in this video, the cord is only being cut some 4 or 5 minutes later. There's no need to stress and hurry with that part of it. So staff are in the unit. Stuff is all there. I think there's also now, you can have a set of stuff permanently there, but it's also very practical to have mobile units, bridges, towers, different terms that are available, so that the things can be brought right there. And also that immediate comes with continuous, and therefore transporting the baby either with mother or with other, a partner or a family member, can then also be done without separation from the supportive technology that is there. So
okay, I'm gonna jump in right there, Nils, because now we're stepping on Chinyere's toes, because Chinyere is going to tell us about the stuff and the systems and the technologies. So Chinyere, don't forget to unmute yourself. Perfect. And walk through some of the stuff and the systems that we need for iKMC.
Thank you so much, Shreen, and greetings, everyone. Yes, the question always comes, what are the things that a hospital facility will need to them to implement immediate kangaroo mother care? We'll first of all have to get this big team that we've spoken about, the obstetricians, the nurses, the biomedical engineers, and parent voices. Looking integrally at the facility assessment, you want to check, what is it that you have? If you have your facility needs assessment, what do you have? What can you modify? Are there things you can remodel? Are there things you need to get more of? Then looking at the exact supplies, you want to be sure that you have this conducive environment for both the mother and both the baby. For the mother, you need reclining beds that she can be in that 45 degrees position for kangaroo mother care. You can actually have kangaroo mother care chairs, the wraps, KMC wraps, and then have weighing scales. Wash facilities are critically important for you to have this conducive environment. Now, looking at the equipment, baby, from the baby we saw in the video, the short clip video, right from birth, this baby needs the oxygen supply source. So you have panel, either you can have panel oxygen, or you can have oxygen in a cylinder, or you have oxygen concentrator. So that technology is key and remains critical for these babies to survive. And then you have a monitoring parameter for you to monitor this oxygen. That is the oxygen concentrator. And this will be one that will be tailored to a small baby, not the finger ones, not the adult pulse oximeter monitoring. Then you have oxygen concentrators, because you need a source of oxygen for this baby. CPAP is critical, like we've been told, because this CPAP will help the baby's lungs to inflate and prevent this baby's lungs from collapsing, which is critical. Then you have to look at your other systems. This equipment, who is maintaining them? So all these have to be integrated as you plan. So you have to have a team, including the doctors, the nurses, the biomedical engineers. You have this team so that you don't have a pipeline of equipment that are broken down. Data is key. Quality data is imperative as you're planning, looking at your systems. So you have to track progress and be able to monitor how far you've gone. And within the systems, again, as you move along, trying to get a committed team, trying to get everybody's buy-in, you need to have guidelines. You have to have guidelines. You have to have written protocols for people to follow, so that at the end of the day, you are able to deliver quality care for this baby. So like we've said, it is the same quality, comprehensive care for these babies. It is only the place of care that has changed. From the being in a lonely incubator where you can have more infections, electricity that is interrupted, to the mother's chest that is more conducive. Thank you.
Thank you. That was a perfect segue over to Silke. Silke, I want you to tell us a little bit about how this environment has really changed from 26 years ago when you delivered your preterm infants, and your babies went into into the incubators, and there was a long stretch of time before you and your partner were able to actually interact with your baby. So tell us a little bit about your personal experience and how far we've come since then.
Yeah, thank you for also giving the parents and patients a voice in such a panel. It's really a huge journey we went through the last 26 years. In my situation, 26 years ago, I'm living in Munich, so in a quite developed country, very rich country also. We had the classical visiting hours, only 3 hours in the afternoon, and there was one camping chair where all the other parents had to share with us. So that means there was only the opportunity to kangaroo or skin-to-skin care when we were able in the end to get this chair. And so my husband, for example, he had 3 months to wait until he had the first time to really hold his son, because there was always the decision who is allowed to kangaroo, the mother or the father. And it was also then in the end the question of how long someone can kangaroo and stay there. And that influences, of course, a lot the breastfeeding situation, because I was already discharged, and the situation was at this time that a mother who had the children in the NICUs or had the child in the NICU were not allowed to even get the milk pump. So that was at the end a big challenge to even, when you're in the NICU, to pump the milk and to provide the breast milk for your baby. So the situation really changed a lot, not all over the world, but in my country, for example, we fought together with some neonatologists and nurses for really a standardized KMC situation where parents can be, of course, with their child 24/7, where their NICUs, when they rebuild or newly built the hospitals, they looked for facilities for the parents, provided food and so on, because I lost most of my milk until discharge from Lucas. And we also changed laws to be able even to be with your child until the baby is going home after 4 months. So that changed a lot. But in other countries, because we are working European and in the meanwhile worldwide, It's really differs from country to country. And what really influenced a lot the whole situation was the pandemic, because here we had a huge separation situation and still have, where parents are not with their child, and some of them even not until discharge. And what really is the biggest challenge is the wording, because often we call them allowing or visiting. We should absolutely avoid this. We should welcome parents as the main caregiver of their child, because the child is the child of the parents and the family, and not the child of the hospital. And I guess this is one philosophical or even standard we should change in our whole wording, to avoid in the end that we are seen as visitors or seen as someone who needs allowance to go to the NICU.
Yeah, such a fundamental change there to include parents into the idea of the care team, and to break away from the idea that parents are just visiting. I want to introduce you all to Dr. Helga Naburi, who raced home to a computer from the delivery room herself. So let me tell you a little bit about her expertise. So in Cape Town, South Africa, Helga Naburi has been working as a pediatrician and faculty at the Muhimbili University of Health and Allied Sciences. She's really passionate about improving quality of care and optimizing low-cost interventions. Helga, don't forget to unmute yourself. Thank you very much for joining us today.
Thank you very much, and sorry for joining late. I had an unexpectedly long day with lots of research. Thank you. I'm happy. Finally, I'm here.
Yes, we're happy to have you. So let's jump right into questions for you, Helga. How does the WHO minimum care package incorporate into iKMC, and what are some of the key recommendations?
So the minimum package of care is just really everything we have been doing every day. It's just that it is packed in a package, and it includes just low-cost things which can save babies' life. Things like ensuring thermocare, breastfeeding, ensuring that we are preventing infections from the children, we are providing respiratory support, and a key to that also monitoring the amount of oxygen we are giving to the babies to prevent complications. And this goes hand in hand with improving the preparations before the babies are born. So in the iKMC study, what we did is, because this was a randomized control intervention, and we wanted to see whether if you implement iKMC, you'll get a difference from whether you go on with your standard of care. For our country, it was putting the babies in the cot. That was our standard of care. We don't have incubators, so for the other babies, we have some gradient warmers where the babies will also be kept, especially the small ones. Now, if we wanted to really show the difference between the two approaches, we needed to minimize as much the basic causes of death among these children, which could possibly bring differences. So before we started the study, we made sure that we trained the nurses who were working in the hospital, and also we trained the research assistants who are assisting us with caring for these babies. We conducted a training on minimum package of care on the aspects which I've already mentioned. And therefore, at the baseline, we managed to standardize care across all the countries which participated in the research.
Perfect. And Nils, I want to bring you in here. Oh, sorry, Helga. Just to piggyback off, since you both have expertise in South Africa, you both have a lot of expertise with adaptation, and are still having these incredibly successful results with saving the lives of all of these preterm infants. So Nils, piggyback off of what Helga was saying about adaptation and the importance of bringing high quality of care with the tools that you have available to you. Go ahead.
Adaptation in terms of the equipment.
Yes.
So just picking up all the details of Helga, the difference is doing that in a different place of care. So some of this requires significant institutional change. All the sites, Helga, you'll remember we had great difficulty getting CPAP with the equipment that we had. And everybody was trying to learn from each other. Eventually, I think Helga herself was the one who came up with something. And but it took 2 or 3 months. Everybody was clamoring for help. And then suddenly we never heard another word. Everybody was just doing it. So these are institutional learning processes. An individual can be very skilled, but you need to have everybody in the institution knowing how to do it. Applies to CPAP, applies to other procedures. You'll see in Sweden, Norway, we're placing lines, peripheral lines, central lines, without separation. This wasn't done overnight. And so all of these practices, without going overnight, brief separations can be the beginning, but in the routine, the parents should be close. So the adaptation here is primarily making space for mother and partner, other. In our study, we had a woman family member by preference. Doesn't have to be that, it was our study. And so this is another systems adaptation that's required. Helga, perhaps you want to add more to that?
Nils, you're right. In terms of the adaptation and minimum package, everybody was stressed that when we bring mothers inside the neonatal units, probably the infection rates will increase. If we place babies on the mother's chest, maybe that also will cause increase in incidences of sepsis. But when we initially started, especially because we were not really experienced to place babies skin to skin with CPAP on. And remember that CPAP is not something which we've been practicing for a long time. It's just like CPAP was an intervention which was just coming up in Tanzania. And now you're telling people to put the babies with CPAP on mother's chest. So initially it was like a learning curve, but eventually people learned about it and they ended up liking it. I remember like towards the end of the trial, some of the mothers were calling in asking about how much does the kangaroo mother care intervention cost, because I would like to be part of it.
Mm-hmm.
And elaborate on that, what not only is it putting technology together with skin to skin, but skin to skin as such required training and safe technique. And so we had a technique that ensured protected airway and ensured a protected position in the fetal position that supported breathing and that would prevent any obstructive apnea. And this had to then be added to all the different care and support that was provided. So that was another important adaptation.
Perfect.
Yeah.
Chinyere, I hear you jumping in. Go ahead.
Thanks. Yeah, just to also type in that one other major adaptation that has to be carried along as we plan is to change the perception of other health workers. Because many of them believe, oh, why are you bringing iKMC that it's more like a second class in terms of intervention? So you really need to have targeted advocacy. You have to mobilize, you have to sensitize, you have to get a committed team together. And this will go along through policy, management. You have to get the obstetricians because you have to get their buy-in. They were initially grappling with, oh, when you have kangaroo mother care for babies who are stable. Now you're saying that immediately after birth, you should start this baby on skin to skin on the mother's chest. So you need to convince them. You need to have evidence to go along because that evidence goes a long way. You have to show them the details of the results from the study. whereby initially we're saying that kangaroo mother care will reduce morbidity and mortality in our low birth weight by 40%. And now this study has added that if you now do it immediately without having to wait for these babies to even be stable, in quotes, where many of them would have died by that time, you have an extra 25% babies being saved. So this will actually be like a monumental shift for us as we move towards SDGs. And looking at that, you now have to carry everybody along. You have to be sure that you have all it takes to, for you to start moving ahead for the implementation, including the technology, including the monitoring. Baby can have phototherapy. We need phototherapy if the baby is jaundiced. So all these technologies will have to be put together. This baby will need point of care equipment. So because it's a sick baby, you still have to give the same quality care. The only difference is now on the mother's chest. So you should be able to have facilities to monitor the baby's glucose. You should be able to monitor the bilirubin of the baby because they can have jaundice. You should be able to give fluids and have syringe pump, etc., etc. So this is quite key. And then carry everybody along and change their perception. If they understand this integral part of what you're doing, that will give that shift and the reorientation that you want to get once you have their buy-in and full cooperation. Thank you.
Mm-hmm. I love the way that you
Perhaps I
phrased
can-
that you need to really pull everyone along and, get them to the table, convince them with evidence-based research, and then, work together as collaborators. Go ahead, Nils, I heard you jumping in.
So we did not do this in the immediate kangaroo mother care study, but for the zero separation, a key person that's forgotten can be the anesthetist. And anesthetists are the first to notice the benefit of circulatory support to the mother. Their anesthetic requirement work is improved. Mother's well-being is improved. So the anesthetist should not be forgotten in this process.
Mm-hmm. Perfect. And Silke, that was a perfect segue over to you in thinking about the mother's needs and also the infant's needs and how those can work together in concert with iKMC. So I just wanted to open up some space for you if you want to weigh in on what's being discussed and really centering mothers in this process.
Yes, I guess what really is important is, as it was already mentioned several times, that there is education and training necessary for healthcare professionals. As I mentioned before, we are not visitors, or even for the immediate kangaroo care, that the father or the partner or the other family members are not kicked out of the delivery room like it was in the pandemic, and also in some countries it's even the case. So this the mother needs a person with her to really be supported. So when something happens, that she really gets supported, immediate kangaroo care can also be provided, and that it is really seen as a medical treatment. I mean, what we have experienced is that it was always seen as, that's only for bonding, or it's only for emotions. And that's not true. I mean, we know now from all this evidence that it's the best what we can do. It's increases the survival rate. It's stabilized even then the breastfeeding. Well, first it initiates it, but later also you have a much more stable situation. And we all know how important this is later in preventing neck, or to also increasing the weight. And finally also that these children go home earlier and have a better outcome when we really provide immediate kangaroo mother care to this baby. And one of the key things is what Nils said, it's zero separation. And I'm often criticized on demanding a zero separation policy. But does this mean that the parents always have to be there? I'm often asked, and I said, well, of course the mother needs to go to the restroom, or maybe sometimes the mother needs to go home and also see the other siblings. But the key aspect really to understand what does this mean is the change of the philosophy of a hospital or a unit, and it's really changing mind. And this is a long journey, and the evidence now will help us to really push and move forward. But one key element is to understand the parents are the main caregiver, that the parents should not be separated, that they have space, because we also discussed before space, facilities, and what I always say, we also need food. We need something to eat and we need something to drink. There needs to be space that we can eat and can drink. I at 4.5 months only sandwiches. We were not allowed at all to drink and eat on the NICU. So this is also one of the reasons why I lost all my milk, that there was no food for me. And this is something what we really have to understand from a global perspective. We have these very tiny babies in the high income countries. We have in the different countries, the different challenges, but we all, in wherever we are, we need this immediate kangaroo care philosophy. And one of the key steps is to see the parent as a partner and the mom as the most important person for this baby in second one. And then in the end, to understand that everything is together. It's not only immediate kangaroo mother care. It means to feed the mother, to have space, to have an understanding of why this is important, and really to accompany these families to this really challenging journey, because most of these babies are very tiny or sick, and it's worrying for parents when this tiny little, I always say the little frog is sitting here on your chest. It's really challenging for the mom when they feel it and they look not like these big babies, what you have expected. And it feels also different. You're very worried. And to take care also of the mom and of the partner also is very important, because it's not only immediate kangaroo mother care. It is so much more. It's a whole philosophy in the end, what needs to be understood, to train, and to really implement into the everyday practice.
And education is such a big part of that, as you mentioned. So I want to play you all a video comment that we got from Dr. Nalini Singhal. Dr. Nalini is a neonatologist who has done iKMC work in Tanzania, Ethiopia, and Canada. Nalini is actually in India right now, so she recorded this video comment for us, not knowing if she could join us live. So have a look at her comment.
We always have to remember that one of the first things we've got to do is to make sure that our education programs integrate these things effectively, so that our messages are very, very clear, that all the care that all the essential newborn care we provide can be provided while the baby is getting immediate KMC. And you might turn around and say, well, how am I going to weigh the baby? Yeah, sure. You do have to separate the baby to weigh the baby. But in order to do that even, there is not that bit of an urgency. You can at least wait an hour to 90 minutes to do all that and to complete your examination, and then decide how you're going to proceed. So I'm going to urge all of you to really, really, really think about, why do I ever have to separate the baby from the mother? And saying that I'm doing essential newborn care will not be an excuse, should not be an excuse, and it has been an excuse that we've all used. For example, when I started, I'd think nothing of separating the baby from the mother to examine the baby. Well, do I do that now? No, because I've learned how not to do it. So I'm going to stop there and see if you have further questions on what I'm trying to convince you is best for the babies and the families going forward.
Thank you, Nalini. So I want to invite our audience watching all around the world to drop their questions into the chat panel, and we can get them over to our panelists. Let's start with one from Elahe Rastkar. Elahe asks, one of the limitations for performing iKMC in C-section deliveries is that it's done for most preterm deliveries. How do you manage this limitation in C-section deliveries?
Perhaps I can respond to that. I think Stina, my colleague here in Stockholm, also mentions that here in Sweden, the father is routinely doing the immediate skin-to-skin. So that is a routine in many parts of the world. It can be the partner, it can be an aunt, it can be any other family member. So it's not restricted to the mother. Having said that, as Silke also says, the mother is most important. So if we can do it there, that would be a quality improvement. but zero separation can be achieved in many different ways. I'm sure others could add to that.
Okay, I'll add in another question from Robert Tilia. Robert mentions that some delivery rooms are really cold, including the operating rooms themselves. Does that affect the mother's body temperature in order to provide that thermal care to infants? Chinyere, do you want to take that one?
Okay, thank you very much. It's been noted, and from studies, from Cochrane review, from the current study, that the mother's chest provides enough warmth for this baby to be able to maintain the enough body temperature at the normal temperature of 36.5 to 37.5 degrees centigrade. Actually, it's been shown that the hypothermia was reduced by 70% in babies who have had kangaroo mother care. And we look at the usual delivery rooms. By the time we're even about to deliver the baby, we have to let the obstetricians to say, please, could you take down the fan? Could you lower the air conditioner? And then the baby is moved to another section of the room for resuscitation. So the same concept will apply. If this baby is right there in the delivery room and the mother and baby are taking, baby and mother are in iKMC position, skin to skin, and everybody has understood that the primary person there at that point is this baby and this mother. So this, we won't have air conditioners on, they have to be reduced. So studies have shown that this temperature regulation is key with the babies who are getting kangaroo mother care. And furthermore, it also studies have shown that a mother's lactating breast actually produces more heat than even a breast that is not lactating. These are all part of the sciences that are backing iKMC. So no episodes of hypothermia has been noted significantly. And again, if the mother is not able to give kangaroo mother care at that point, you have the father or a surrogate who can be an auntie or a sister to deliver that care. So if everybody understands and everybody has keyed into making that concept to be successful, we won't have this baby go hypothermic. Thank you.
Mm-hmm. Go ahead, Nils.
Perhaps hypothermia can affect the mother, as the question was put also. The World Health Organization does recommend that the delivery environment should be 26 degrees. The anesthetist and the operating staff might ignore that, but they shouldn't.
Yes.
Perfect. And I'm getting lots of comments here. Karen Reed says, we're starting to see more immediate KMC here in the UK. She says delivery room cuddles, but it's a slow change. There are still many concerns about temperature control and maternal tiredness. We've talked about some of those. She also mentions safety concerns. So are there any other safety concerns that Chinyere or Helga you can weigh in on that you often find from healthcare professionals that they're worried about the safety of the infant?
So initially, people are concerned about the safety of the infant, that either a mother would accidentally sleep over the baby. But we did not see this happening in the study, as the mothers were completely attached to their babies. But also the other thing which people are worried about was maternal complications, because this is a mother who just gave birth, so anything can happen. But we had our nurses well trained, both the pediatric nurses and the obstetricians, how to pick these complications, and we had obs and gyn doctors who are on standby in case such occasion occurs. We'll report to them and will come to see the baby. And the other safety issue, which was of concern, as Nils said earlier, is for the babies to obstruct their airway when they're with their mothers on skin to skin. But we manage this through the use of the special binders, and because the healthcare workers were adequately trained, we had the kangaroo mother care supporters who were present in the KMC rooms 24/7, and they were responsible for teaching the new mothers and trying to see that this is not happening.
Okay. And to build off of that, 1 second, Chinyere, Carrie Galitko says, thank you, Dr. Naburi. When you mentioned mothers and babies were completely attached, did you mean with the binders?
So they were emotionally attached. So sometimes the mother will not sleep because they just feel like that moment with their babies. So it was like they were emotionally attached, not attached with the binder. Thank you.
Okay, Chinyere, go ahead.
Okay, thanks. Yes, discussing with colleagues and trying to excel and advocate around kangaroo mother care. One major concern, especially the neonatal teams, are like, what if this baby gets complications? All the usual complications that we have with preterm babies. And this is where the technological aspect comes in. When the iKMC study was done, this baby was just put on the mother's chest. This baby still had the same quality care while on the mother's chest, meaning that the baby had CPAP for respiratory support, there was oxygen, there was multi-parameter monitors, whereby you're looking at the baby's respiration. Even in the study, it was actually some of the mothers that were monitoring, they're seeing the SpO2, they were seeing the respiratory rate of this baby, seeing it on the monitor. Then you also have pulse oximeters to monitor. So again, KMC even gives us that added advantage, whereby, especially in low resource countries, you don't have enough staff, you don't have enough staff, where you have maybe a ratio of 10, 15 babies to one nurse. So the mother doing that iKMC, actually, the mother is like the best nurse in this instance, whereby she will note the time the baby is maybe trying to throw up, or when the baby is having like the breathing is not regular. So that monitoring is key. Then they're also worried about this baby getting jaundiced. If it is that this baby is skin to skin with the mother, now you can miss some of the complications. But with iKMC, there has to be all those standard technological equipment. Phototherapy machine should be there, and you should be able to monitor the irradiance that is coming out from that phototherapy you're delivering to the baby to know when you're giving intensive or when you're giving conventional. So all the standard technological equipment will have to be ready for this baby and mother, in as much as the care, quality care, is now on the mother's chest, and monitoring is key and optimal in the along line. Thank you.
We have a question coming in on monitoring, Chinyere. Azadeh Ranjbar says, what time do you check the baby's temperature for the first time after birth?
What time do we check the baby's temperature for the first time after birth? At least if we use the essential newborn care criteria, within the first 1 hour of delivery, you monitor the baby's temperature. That's why you're giving vitamin K. So, like we said, all essential newborn care, all advanced newborn care, CPAP is on the mother's chest. So within the first hour of delivery, you should be able to monitor the baby's temperature. And this can go depending on the circumstance. If it is you have any perception that the temperature is low, monitor the temperature of this baby right within 15 minutes from birth, even while the baby and mother are in the skin-to-skin position. And in the video that we watched, we saw that immediately the baby came out, the baby had the plastic wrap, and all this helped to provide heat in as much as maybe it's on the mother's chest. So you're really monitoring for that temperature critically. And sometimes really for one of the equipment that was there, even during the iKMC study, and which is key for small and sick newborns, is to still have a standby radiant warmer. Like if it is you have to do a procedure, etc., or the temperature drops for any reason, or have availability of that radiant warmer, whereby you can briefly warm this baby up and while you're doing your procedure. So at no point do you lose your warm chain in trying to give quality care to this baby. Thank you.
We do have a question coming in on the different circumstances. So Sergio Marba asks, can you talk about immediate clamping in the serious baby? Maybe Helga, you could take that one on, or Nils, looks like you're ready to jump in.
So yes, If there's a serious baby, clamp immediately, take the baby to the resuscitator as you're used to doing. Then start thinking, now, was I too hasty in clamping? And was I too hasty in separating? Yes, Silke smiling quietly to herself, because yes, with over time, it's our stress and our own panic that causes us to act sometimes. And as we develop the confidence, yes, we don't have to clamp immediately. We can do CPAP immediately. So yes, we should practice safely. And then when we've done the procedure, first, do safe. Second, think, I can delay this. Third, restore the habitat. Restore the baby to skin contact as soon as you've finished. And if the baby's cold, it's because you took the baby away and because you didn't follow the WHO recommendations. If you have an environment that is the 26 degrees required, it's quite warm, you won't have a problem. I've used a heat camera. A baby can become cold in 90 seconds if it's cold. So your environment does matter, and you can prevent hypothermia. Mother skin-to-skin contact does so profoundly, but a wet baby will lose heat even on a mother. Must be dried.
Silke, it looks like you wanted to jump in.
Yes, it's for us, for the parents, for sure, safety comes always first. And also, of course, how experienced and how good the team is also treated. So this is why we also push a lot simulation trainings and also trainings as a team, so that not the doctors separate are trained and the nurses, so also that you mix this, and several times a year. We always compare it to flying. Nobody would go into a plane when we would know that they are really good trained, and most of the team members don't know each other. So also you sometimes are mixed up in such a delivery situation, and you know what you are doing. And also the more experienced one, of course, can also, like Nils said, think a second time, is this too hectic, or is this something where we can still have the situation where the baby can first go on the chest. But for us parents, of course, is always important, safety first. And as Nils said, when there is the situation, you have to do this, that as soon as it is possible, also when the mom is sick, like I had a preeclampsia and a HELLP syndrome, I was resuscitated myself, 3 days lying on intensive care unit, and I saw my children the first time after 4 days. But even then, kangaroo care was not possible at all, or any kind of support of breastfeeding. So there would be much earlier the opportunity at this time to have and hold my baby, or maybe my husband. And so therefore, it's also always thinking, when the mother is sick, the baby is sick, what can you do to ensure immediate kangaroo care? That there are often a lot of opportunities. It's the changing mind thing, but again, safety is always first, of course.
Okay, I want to bring in more comments that we're getting in from our Q&A panel, Q&A box. So Asrat says, jaundice is one of the most common problems in preterm babies, and phototherapy can be given for 1 to 3 days, which separates the mother from the baby for a while. Does this separation affect any of the results that you saw in the studies? Go ahead,
Perhaps
Nils.
the first thing I would say is that jaundice does not appear immediately. It comes later. And in our study, doing phototherapy together with skin-to-skin would have been a co-intervention, and we then said we separated for that reason. But there's many, many places that are showing there's no need to separate. And there are a number of innovative approaches. If you have billy blankets, if you have various things. So it is not a contraindication for skin-to-skin contact.
Okay, and a question, Nils, building off of what you said earlier. Sorry, Chinyere, and then I'll get back to you. Alejandro Dinerstein asks that you mentioned the importance of working with anesthesiologists. Can you briefly comment on the strategies used with those professionals?
Strategies. As Silke says, there's a team involved. The obstetric neonatal environment has been divided, and it's been a huge thing getting them together. And then we forgot about the anesthetist, and he's responsible for the mother. So yes, in answer to, I can't see the question that you remember too carefully, but having the anesthetist involved if we want to do this immediate in the operating room, is critical. The safety of the mother, his call, whether a surrogate should be in there, then it's a whole procedure. Having a surrogate in the operating room can be done, but it can't be done suddenly. It needs to be done with preparation and training. Have I answered your
Preparation
question?
might be, thank you. Preparation might be the answer to this next question that Leah Harris is asking. Leah says, we're in the process of conducting a study on mothers' perceptions of iKMC here in Yemen, where the general belief is that mothers don't want the baby with them immediately after birth. She says results are pending, and this was the same general belief when I worked in Afghanistan, where iKMC implementation failed repeatedly. Have you encountered this challenge?
Helga?
I think from the iKMC, the results are on the contrary, because I remember, like, even from the very early days when ourselves as healthcare professionals were scared of the iKMC because we were like seeing it for the first time. We went for the standardized training in India, and in one of the occasions when we started seeing these mothers with their babies, I remember the first mother, the reaction she gave was like, this is unbelievable. It's a very beautiful experience. And she was very happy to hold her baby immediately after birth. And when we went back, this is exactly the reaction we got from the mothers. So as long as you prepare them in advance, before enrollment, you tell them the possibility of the arm where they may fall in, and you tell them what they can expect. And then we had the nurses who are very supportive. So the moment this woman holds the baby skin to skin, they would give this like a wow experience of holding their babies. And they were like, they didn't want to be separated from their babies, to the extent that when the babies were like, if a baby was much sicker and you wanted to take the baby from the mom to examine, the mom will be like, can I please hold the baby a little bit longer? And you could see that they were completely like depressed when you take a baby away from them, even if you're placing a baby in a radiant warmer very close to her bed. So I don't know, probably is more of the cultural differences which can cause the differences in the experience they are seeing.
Okay. And I have a few questions coming in about the nitty-gritty of the tools. So Abera Bedishu asks, what is the mechanism of restoring heat of the plastic applied in iKMC? And Rova asks, which cloth is best suited? I'm assuming that's for the bundling of infant to mother's chest.
A wet baby can get cold very quickly. And the plastic was very popular and is still used. It's not the only way of doing it, and it's not my favorite way of doing it. It happened to be what we were able to film. So our recommendation otherwise is that we should not use those towels that you saw, except we use cotton to dry by dabbing. And then we use more dry cotton cloth to cover. And it must be covered with 2 or 3 layers. Then units do things differently. I'm sure Chinyere, Helga, you can elaborate on this. Towels are very coarse for a newborn skin.
Okay, and we have another question coming in. This was a great one from Roger Ilif, and Roger asks, can you recommend the most relevant material that can be used in developing grants and programming? I wonder if we could maybe go around the room and everyone could give us just one resource that you would recommend our audience look into after this chat. Silke, should we start with you?
Yes, sure. Well, there are several grants available, but what we can share from our patient-parent community already is that several of our parent organizations, because of their fundraising activities they are doing, they even finance programs to implement them in hospitals. Well, it's normally not the job of parents to educate or to pay the education and training for healthcare professionals, but also we ourselves, we are paying paying for training for hospitals when this is not in the governmental institution, even in my own country, in Germany, but many people for you for sure cannot believe that also here we have to save money for this. And of course, there are different programs from other bigger foundations available, but I would also strongly recommend to collaborate with your national parent organizations together in checking what kind of trainings are available, what kind of trainings are available in your language, and so that really the philosophy of infant family-centered developmental care, immediate kangaroo mother care can be implemented. And parent organizations are really powerful. We use often World Prematurity Day, what EFC and I has founded with the parents to establish, to get enough funding, because we have very well understood without your expertise, and the better you are experts, the better we can implement in the end the iKMC or the infant family-centered developmental care philosophy. And we have to work together. And therefore, if you not have a parent organization, please reach out also to us. We help to set up parent organizations in the meanwhile in over 100 countries.
Thank you, Silke. Perfect. I just want to get to all the other guests as well. So to repeat Roger Alef's question, is there a package of information that summarizes all the requirements of the 4S that you've outlined that you can recommend for building grants and programs? Nils, do you want to take that one on?
Yes, the World Health Organization has a 6-item package, which is very similar, and that's in a policy on an evidence base that you can take out the health system building blocks. So the review that we've looked at says you need all of them. You can't just make a difference with one of those. And then you need to work with the EFC and I as well. The community is the critical partner that's often forgotten.
Chinyere, would you like to weigh in on resources?
Yeah, I wanted to add in around the issue about having national guidelines, because that will go a long way to actually let everybody know what's to be done, when the baby is to be put in KMC position, who will do it, etc. Because for us in Nigeria, we actually have a document that is Kangaroo Mother Care, National Kangaroo Mother Care Operational Guideline, that is currently being disseminated and being cascaded. And for us as a country, we've also imputed the iKMC component into that material. So it's believed that if you have guidelines that is now taken both at the national and subnational level, facilities will use this as a hand leading for them to look through to see what can they do, where do they start? Because one chapter in that operational guideline is even facility implementation of kangaroo mother care. So it's actually, that is elucidates all the space, all the infrastructure, all the materials, all the supplies, all the equipment that you need for kangaroo mother care, and then the monitoring. Then again, to say that for us to start, we need to get also to antenatal. Let these mothers hear about it. It's not just when they deliver, you're telling them, oh, you have to put your baby in iKMC position. If it is when she was attending antenatal care, she had heard about kangaroo mother care, she had seen information, education, communication materials like posters and job aids around iKMC that are around the delivery rooms and in the antenatal care. By the time she's now being told about iKMC, she will now say, oh, yes, I've understood it. Oh, I heard about it during antenatal. So it's more of a seamless transition. And then the third point is also for our colleagues, because one of my neonatologists asked, are you saying now that if I have a 600-gram baby, that I'll just put that baby in iKMC position? And when we had this discussion, it's like, why don't you start from, why are you starting with a 600-grammer as, for your facility? Why not start from a 1.2 baby? At least by the time you have that 1.2, even the iKMC research, the research was between 1,000 grams and 1,800 grams. That's the age range that was utilized for the iKMC study. So, speaking as neonatologists, when we had that discussion, it's like, why don't you build in the system, get everybody on board, have the team, Start from the babies who are not too complicated with a lot of comorbidities. Start with babies who will not, when you have problems, everybody was like, oh, the baby did not make it. That will give everybody that negative perception. Why don't you start with the babies who are still low birth weight, 1.2, 1.3, 1.5, and then learn lessons. As you go, learn lessons, everybody will now march along as you move towards the smaller sized babies. So that experience goes a long way to strengthen the team and lead everybody to still give quality care and save the multitude of babies who are dying from not being able to have skin to skin and EPISODIO. Thank you.
Yes, absolutely. Thank you, Chinyere. I'm going to give the last word to you. That was a beautiful way to end today's conversation. And I just want to thank all of our panelists for joining us. Silke Mader, Dr. Helga Naburi, Professor Chinyere Ezeaka, and Dr. Nils Bergman. Thank you for our audience and our live translators. On behalf of the American Academy of Pediatrics, thanks for spending this hour on iKMC. Today's show will be posted on our website along with episode 1. Stay tuned for episodes 3 and 4 to come. Take care, everyone.
Thank you.
Thank you for having us.
Thank
Thank
you.
you, everyone. Thank you.